Hi, this is Dr. Ty Vincent. Testosterone is one of my favorite things to talk about. Of course, most people know that. And there are a lot of concerns that the general public and the medical community has about testosterone and testosterone replacement therapy, ranging from could it cause cancer to heart attacks and strokes, cardiovascular disease risk in general, fertility, blood clots, all these things that people are concerned about. Some of these concerns have some validity or a lot of risk factors and you just don't know, which means there's a higher chance. You should be a lot more cautious, depending on the circumstances, starting those men on testosterone at lower doses, gradually titrating them up. At least that's my suggestion. But this question of whether or not it was safe for cardiovascular disease purposes specifically in older men has been asked for over 20 years. There were a couple of studies in the early 2000s that I remember talking about. They came out and they raised a little bit of concern for people because they showed that older men in this group, they did a general study with a large group of people, but older men that had existing cardiovascular disease, there was a little spike in heart attack risk. And it was in the first 6 months after starting therapy. Now, you're not going to grow plaque in your arteries in 6 months. So no one should have ever thought that meant, testosterone replacement might cause heart disease. Really, what that demonstrated, in my opinion, is that men who have bad hearts to begin with and low testosterone, which usually means they're not doing much physically, right? Like they're not pushing themselves. They don't have the energy or the motivation to do it. You put those guys on testosterone too aggressively, let's say, or without proper counseling, and you might push things too fast for the heart that they have, right? And you may induce some heart attacks because of this sudden increase in activity and virility and motivation and things like that. That makes total sense. So when I read those studies, I started looking at the men that came in, if they were older, if they had risk factors. I would either ask if they had cardiovascular evaluation that had been done recently and I knew everything was cool before we started them on TRT, or I would send them for a coronary calcium score, which is a cheap, easy CAT scan based test. Most places anyone can go into a radiology office and just pay for it cash because it's usually not covered by insurance, not yet anyway, and they might be from $100 to $200. But they do a limited CAT scan of the heart and they look for calcification in the arteries. Your arteries are supposed to be soft tissue with no calcium buildup whatsoever. So if you see calcium, it shows up as bright white on the CT scan. It's very easy. And then the computer software gives you like a calculated score called an Agatston score. If you have a score of 0, that means you had no calcification seen in your coronary artery system and you're pretty much clean. You could have some really early soft plaque that's still mostly just cholesterol and fat and whatnot in there and it hasn't calcified yet. But if it's that early and that mild, you have essentially no risk. So it's pretty much a green light. If somebody has a score above 100, everybody's going to have their own cutoffs, right? If you see high scores, you might want to say, okay, we got to go really slow. It certainly does not mean that you shouldn't give the man testosterone replacement because it is the key to him ever getting a healthier heart, getting his cardiovascular system doing better, his muscles under better condition and using more energy, his metabolic syndrome comes down, diabetes rates come down, everything gets better. But you want to ease into it with those guys. So those came out and then there were, a lot of studies. If you look on PubMed, which is the site I usually use for medical research, you go in there and you put in, testosterone replacement, cardiovascular, myocardial infarction, mortality risk, like whatever, some keywords. You get a whole bunch of studies in the last 20 years done on testosterone looking at this question. There was a recent one that came out, which is why I decided to do this post. Not that recent, but a few years ago, New England Journal of Medicine though, so the big names, right? That's what gets attention. So this study came out of the New England Journal, and I've heard people talk about it now. I just saw a head endocrinologist from the Cleveland Clinic at a conference that I attended just as a CME conference to get my credits. And he was the Cleveland Clinic endocrinologist, and he was talking about testosterone replacement in men. This was just a couple weeks ago in May of 2026. It was hard to watch. It was hard to sit through because he's talking about how, below 300 is still the cutoff. Nanograms per deciliter below 300 for testosterone deficiency, and they treat their men to get them in like the 500s or something. And that, that's it. That's all they need. They don't need more than that. He kind of mocked this list. Here's the list of symptoms men might have with low testosterone. And it was, of course, poor motivation, low mood, fatigue, bad sleep, less energy, all this stuff. And he's just kind of joking, like, who doesn't have all those symptoms? Like, exactly, man. Like that's the problem. Everybody has those symptoms, and it's because pretty much everybody now is low on testosterone compared to where we really should be as humans. And therein lies the problem with all the research that's been done. So this study from the New England Journal in 2023 talking about the cardiovascular safety of testosterone replacement therapy. They always start out with saying things like, the cardiovascular safety has not been determined. They're going to say that in every study forever till the end of time. Of course, we we don't prove things in medicine so much. There's always like, oh, you need more research for this at the end of it. And at the beginning, it's this hand waving, oh, we don't really know. And they talked about, so this was the study where they did the fanciest, what's considered the most valid setup, right? It's a multi-center, randomized, double-blind, placebo-controlled, non-inferiority trial. Non-inferiority is sort of like, we're just comparing whether this is worse than that, but they're not really trying to see how beneficial it could be. It's more about, we're just trying to make sure it's safe. So in this one, they had 5,200 and some men. They were ages 45 to 80, and they had pre-existing or a high risk of cardiovascular disease. So this is a high-risk group. So that's good. If you want to assess safety, you want to look at the high-risk group. And of course, they were using a cutoff of 300 to determine whether they were low or not. Patients were randomized. And so that's one of the benefits of this. It's the only one I've seen looking at testosterone treatment going forward prospectively and evaluating cardiovascular safety that was truly randomized, which means they didn't pick based on certain proclivities or characteristics, and they didn't let people choose. People had to be assigned randomly. So there is something about people who choose a certain therapy versus not a certain therapy where it does skew the outcomes, and there's a bias there. So randomization, this is the only study that has it as far as I've seen. They gave them testosterone gel, the 1.62% testosterone gel that's available at the pharmacies. That will never get any man anywhere near where he will do optimally well. Like I always talk about 2,000 or above. You're not going to see those levels on these guys. The other thing is, they usually give these gels once a day. If you use a topical testosterone, or really any hormone that you apply topically, it absorbs pretty quickly. It peaks around 6 hours or so, and then they start to decline. And by 18 to 20 hours, it's totally gone. You're back. So because there's that big excursion, that big pharmacokinetic peak and then drop, where you retest people in terms of how many hours after application means a lot. And none of these studies ever standardize that. They don't talk about it. They don't standardize that part. They randomize into the groups. So that's a problem. They use the gel, and it says that they're trying to just maintain their levels between 350 and 750. So that's within the current reference ranges. But again, as I rant about repeatedly, if you look at the reference ranges from LabCorp, was the lab I used to use in my clinic in Alaska, their reference range in the early 2000s, 20 years ago, was from 347 to 1197. So basically 350 to 1200. Huge wide range, but it went to 1200. The current reference ranges, because men have just been declining, are now publishing about a 750. So in this study, they're going by these modern reference ranges, which are already the wrong target. I mean, it's already almost useless information, unfortunately. And they're aiming for this very low bar, which they can achieve with the gel, but you'll never get a man to 2,000 with the gel. So this isn't even relevant to what I do in practice, right? It's relevant to people who give these very small doses and have these very low targets. But that's conventional doctors they're not really seeing the benefits in that so much either. So in this study, what they found was, if you look at the methods and some of the details of studies, things are important that they don't really highlight. It said the average duration of treatment was 21 months, plus or minus 14. So that means some men only went for, 7 months, and some for 35 months. And yet they're trying to compare the cardiovascular risk within that group with such diversity in terms of duration of treatment, which I think is important when you're dealing with a long-term disease that's a chronic illness, not an acute illness, right? So that kind of means the data is not that transferable. It's not that meaningful, let's say. But they did not see, so the reason this made so much kind of press, and the guy, Cleveland Clinic endocrinologist, mentioned this study, is that it showed that there was no increased risk. So basically, they proved their point, I guess, that giving men this low amount of TRT and aiming for the current reference ranges did not change their cardiovascular risk. But it's interesting, like the way they designed their study, they showed basically no difference at all, which if you look at older research, which I pulled like 5 or 6 more articles off with the same sort of search. They're just a little bit older. I'll go through them in sequence backwards, but they have shown consistently a dramatic reduction in cardiovascular mortality and risk in men using TRT. So this big study that came out in the New England Journal, which means lots of money behind it, lots of prestige, lots of bias, lots of influence behind it, came out and very graciously said testosterone replacement appears to be safe for cardiovascular disease, which is fascinating when just pulling some other articles from the last 20 years. This one was from 2017, so 6 years prior to that. It was not a randomized trial, but still, I think this is the one that I like to show people. Yeah, I've been using this in my conference lectures for a long time. It says long-term testosterone therapy improves cardiometabolic function and reduces risk of cardiovascular disease in men with hypogonadism. A real-life observational registry study setting comparing treated and untreated control groups. So they have a control group. In this case, it was men who just opted out, didn't want to do TRT, and then men who did decide to do TRT. So what they looked at was 656 men whose average age was 60 years old. And it went from plus or minus 7, so 53 to 67. Older guys, all older than me. And they had low testosterone below 300, that's their usual parameter. So 360 of the men opted to go ahead and do TRT. And they did standardize their treatment. They gave them injectable testosterone, but it was testosterone undecanoate. And if I haven't talked about that, testosterone undecanoate is a particular ester that has been pushed and popularized for urologist offices because the hook on this is that it lasts a very long time. So the different ester, that second word after testosterone when you buy a product, testosterone cypionate, testosterone enanthate, testosterone propionate, some kind of 8. That means it's an amino acid, organic acid of some kind. Just the 8. It's not really that relevant, except for the different ones have sort of different binding affinities, meaning they will let go of the testosterone into your bloodstream at different rates. So the ones that bind more tightly and for a longer period have a longer, slower release, right? So the testosterone undecanoate purportedly can last a month or two. I've seen different reports, but in these studies, and there are a few of them here that I pulled, they all do like 1,000 milligrams every 12 weeks, which is nuts. I mean, it's such a tiny dose. So this is a baby dose of testosterone, in my opinion. Plus, I tried using testosterone undecanoate. I don't recommend it to anybody because you only get about half the plasma levels that you would expect from the same dose of any other ester because it doesn't let go, right? It doesn't really want to let go, so it doesn't. And you only get half your product, apparently. And it does not last 12 weeks. It doesn't even last a month. When I used it, I could feel that it was wearing off after 10 days, 12 days. It didn't make it any longer. My levels dropped, were terrible. I had to quit using it and go back to cypionate or enanthate. Just FYI. So the men in this group, given this pathetically small amount of testosterone. So again, it's 1,000 milligrams over a 3-month period. And based on my experience with testosterone undecanoate, it's more like getting 500 milligrams in that amount of time. I normally suggest that men get about 2,500 milligrams, 2,000 to 25 milligrams per month. So like 250 milligrams every 3 days. And that's 2,500 milligrams per month because you do 10 shots in a month, right? This is such a small amount compared to that. And yet they had 360 men get treated, 296 men opt not to get treated. And they watched them for, I think it was a mean of 7 years. Okay, so they watched them both for 7 years. And the results were that what their primary outcome they were looking at was death, which is always a meaningful primary outcome for research. But they showed the men that did use testosterone, there were 2 deaths, but they weren't cardiovascular related. So, something that they didn't link to testosterone at all. And that was out of 360 men. In the group of men that did not use testosterone, 296, there were 21 total deaths, 2 that were not cardiovascular. So 19 people died out of 296, 0 dead if they used the testosterone. And again, this was such a tiny amount of testosterone over time that it was given. So based on their statistics, you can't really divide by 0. So I was like, well, how do you decide what the reduction is? So based on their analysis, they decided to declare that the use of testosterone replacement, at this regimen at least, showed between a 66 and 92% decrease in mortality. Now, that's insane. Cholesterol drugs have never really demonstrated any meaningful reduction in death. They market them just to lower your cholesterol and also to reduce your risk of non-fatal heart attacks. That's what they've been demonstrated to do. They don't save lives. And yet doctors tell everybody to take a statin drug. This one article, the author is Traish, Traish, and it's in the Journal of Cardiovascular Pharmacology and Therapeutics in 2017. I was trying to search this article because this is the one I've always used for lectures in the last 8 years anyway. And it is really hard to find. If you just put in the keywords, like I said, testosterone, cardiovascular, whatever, you'll get the New England Journal study for sure. Because it shows, it's safe. But it doesn't say that, it doesn't even begin to suggest that it could be beneficial, right? It's just, we showed that it didn't make anything worse. So I guess you're okay. Whereas a study like this, published in another prestigious journal, it shows this massive reduction in death. This should have been front page news. And no one heard of it. I had to look around. I was doing research for presentations on this every year when I would give these talks. And I found this article and I kept it, and I kept a paper copy, which is a good thing I did because they made it harder and harder to find. If you search in PubMed and just put in all the keywords you think would be relevant, you got to put in the author's name, Traish, Traish. And if you put that in with it, you'll get a series of articles that the same authors participated that all show this kind of thing. So this was a dramatic improvement in cardiovascular outcomes, massive reduction in death. This was published 6 years before the New England Journal article. The one I found previous to that was 2016 in Andrologia. This one is effects of continuous long-term testosterone therapy in anthropometric endocrine metabolic parameters for up to 10 years in 115 hypogonadal elderly men. So these are older guys. This age range was 60, plus or minus a little bit, and there were 115 of them. And again, they gave them the testosterone undecanoate every 12 weeks for up to 10 years. So a long-term analysis. And what they showed in this, they weren't really looking at cardiovascular disease. They were just looking at a lot of health parameters in general. This showed that the benefits in the men that use the testosterone regimen, and again, it's such a small amount of testosterone by my standards, they showed that there was a reduction of hemoglobin A1C, which I'm going to do a whole video on what that test is because it's a great test, but it's the test we use to evaluate for diabetes. So a cutoff of 6.4% is our current sort of criteria for diabetic. 5.7% and above, up to 6.4, is considered pre-diabetes or metabolic syndrome. So the average in the men that used TRT started at 6.4%. So on average, they were diabetic, right? And it dropped to 5.6 on average, which is huge. And that's just from this amount of testosterone. There wasn't another intervention. That means they became non-diabetic, right? And that's what we see. So my wife and I, we treat men with TRT all the time. We get men that are out of shape, overweight, they've got type 2 diabetes, high blood pressure, high cholesterol. And honestly, within 3 to 6 months of us working with them, they're not diabetic anymore. They've lost tens of pounds of body fat. Their blood pressure is better. They're off the medications they were on. This is the most important thing for men's health. These studies looking at safety kind of demonstrate that. So a massive reduction, diabetes, risk, and the blood sugar monitors. There was a decrease observed in systolic and diastolic blood pressures. This is something I run into a lot. Men who are on testosterone replacement, if you go to an urgent care or an ER, your regular doctor, and you tell them you're using testosterone, anything that's wrong with you, just like anything that's abnormal, your blood pressure's high today, your heart rate's high, like whatever, maybe you drove in busy traffic and you were stressed and your heart rate's high and all these things. That's pretty common. They blame it on the testosterone. And I get this from men all the time. I went to tell my doctor my blood sugar's high and he says the testosterone. Like, there's no research that links testosterone to higher blood pressure. It's almost always the opposite. And it drives me nuts that doctors will say these things just because of their own personal biases. There's no evidence to back up what they're saying. And if they bothered to research it, they'd see it's actually the opposite. And then maybe they would be prescribing testosterone for their men who had high blood pressure. And it says there were no major adverse cardiovascular events observed throughout the study. So that's 10 years of men on TRT. This is one from the European Heart Journal, 2015, so another year before that one. Normalization of testosterone levels is associated with reduced incidence of myocardial infarction and mortality in men. So this is one from 11 years ago showing that, again, testosterone replacement reduces cardiac death. This was 83,000 male veterans. It was a very large study. So if you want numbers, the New England Journal study was 5,000 guys, 5,200 and something. This is 83,000 men. And of course, that's not a randomized prospective trial, but it's kind of looking back retrospectively. What they found was that men who used testosterone, and they broke them into men who used testosterone and managed to get their levels into range, again, who knows how long, versus men who used a little testosterone but their levels didn't rise into range, versus men who had low testosterone didn't do anything about it. So what they found, a variety of things, and this is really comparing men with definitely deficient testosterone to men who have a little bit of testosterone, like still not anywhere near enough, but better. And what you have to understand is at the very low levels, every incremental increase is a really big deal. So if a guy starts at a level of 200 and he gets to 300, that's a 50% increase. And he's going to feel that. And his body is going to feel that. So the benefits are greatest early on when you're doubling your level and doubling your level. When you get up above 1,000, the more increased benefits in terms of cardiovascular risk and all that, I don't know where that plateaus. No one will do the research, right? They're doing research on these baby doses and keeping people in this very low range, which is nowhere near men we're ever supposed to be. And they're making determinations based on that, which is why none of this research is really meaningful to me. I want to know how men do if you actually get them to where I believe men are supposed to be, 2,000 or so, where men say, this is where I feel great. If somebody would do that research, I would be thrilled. I want to see the outcome because what I've observed in practice is just the most amazing beneficial thing for men's health you could possibly do. So anyway, this one showed there was a 56% reduction in all-cause mortality. So less than half the death rate if men just used this small amount of testosterone. That's huge, right? What else can we give you from the pharmacy that cuts your risk of death in half in the next 10 years? Nothing. Just this. Other things that they found in this study, the risk of heart attack was down by 24%. I'm not sure if that was so different. There were a lot of other causes of mortality, apparently. Stroke dropped by 36% in the men using TRT. So again, mostly cardiovascular stuff. Huge number of men. Small increase in testosterone. Incredible difference in survival and in cardiovascular. And you can guarantee that along with that was a quality of life enhancement that made the other ones just bonus material, honestly. Like if a man is going to live longer, but he's going to be miserable, he'll usually not be excited about that. But if you say you're going to have, your quality of life is going to be dramatically improved, and you'll enjoy that life for decades longer, honestly. Like if you started a man who's in his 30s, you could potentially prevent all that cardiovascular development, diabetes, from developing in the first place if you catch them ahead of time. Why wait until they're 60 years old and they've been deteriorating for 30 years? I mean, the benefits are even greater when we start men younger. And we don't let them get into this position in the first place. So this one, last one. Promise. I decided to just look for like 10 minutes and pull up the next 5 articles that were there on cardiovascular risk and testosterone. This one's from 2013, European Journal of Endocrinology. Testosterone deficiency is associated with increased risk of mortality, and testosterone replacement improves survival in men with type 2 diabetes. So this was men with type 2 diabetes specifically. That's all they enrolled. They had 581 men that all had type 2 diabetes, and they had low testosterone below the 300. They followed them for about 6 years on average. Well, they had an interesting protocol in this. This is a European study. So they say that their clinical practice, normal clinical practice, it says 85.9% testosterone gel. So I think that's 85.9% of the men were using testosterone gel. And then 14% intramuscular testosterone undecanoate. Again, these studies are all using testosterone undecanoate, which is it's like half the potency, and it doesn't work very well. But this study showed that in men that had low testosterone, so this was sort of in general, not necessarily looking at treatment, not treatment, but men who had low testosterone, they had a higher mortality risk. There was 17.2% compared to 9%, which means men that had lower testosterone, like below the 300 cutoff, were almost twice as likely to die during the course of this study as men who had levels above 300. Like I said, every increment in the low levels makes a really big difference. And remember that in terms of mental health. So the men, the males, young males especially, that have levels lower and lower and lower, 300 is way worse than 350. 250 is way worse than 300. 200 is way worse than 300. It makes a huge difference. And we get guys that are in the 200s, and their family thinks that they have psychosis. They think they have like severe suicidal depression. They have intrusive thoughts. They think they're hearing negative voices and things, but it's all just being generated by this complete and utter lack of any confidence or direction or mental strength. And we get these young men on testosterone, and everybody's completely stunned. So the mental and emotional benefits are so much better than the cardiovascular ones. These aren't very tangible. If I tell a man, I'm going to put you on testosterone replacement so that you don't have a heart attack in 10 years. Okay, but what are you going to do for me today? People want something that's worth living for right away too. So all those other benefits are really why it's so much better and your quality of life is better. But the safety issue is not an issue. I mean, cardiovascular safety did not have to be determined. And that stupid New England Journal article, they're just showing like even Steven on the cardiovascular risk, which means that they must have done this on purpose, because there's just study after study after study showing significantly lower rates of mortality in men who have higher testosterone or who use testosterone. So in this group, just to finish it off, there was a reduced mortality from 19.2% in the men that didn't get treated down to 8.4%. So again, more than half. Like it dropped by like 60% mortality again. So this is being shown over and over and over, and yet we will still have studies coming out in the big journals. So be aware that any study that comes out in the really big name journals has been very carefully vetted by the people high up in the medical industry to be curated into the propaganda they want you to believe. If you do some more digging and you look at other research, especially from Europe and other countries, not America, medical research is a commodity. It is bought and paid for. And they pay millions of dollars to do research to show a minuscule effect for a drug. Like, for example, the cholesterol drugs. Billions of dollars in research probably now have been spent trying to demonstrate that these drugs cause a teeny tiny reduction in cardiovascular risk. And that's all they can show. But there's study after study showing that testosterone, even in small amounts, has massive reduction of mortality. Why aren't we all being taught how to use this instead of blood pressure drugs and cholesterol drugs? I learned all those things, and I look at the actual numbers and like, these don't make much difference. They cost a lot of money. They cause a lot of side effects. They don't really work. It's frustrating. The cholesterol drugs, all this. I get men in my office, they're on all these medications. They're on Viagra, they're on Adderall, they're on blood pressure pills, anti-anxiety medications, sleeping pills. We get them on testosterone, we get their level into the 2000s, and in 3 months to 6 months, they're off all their medications, and they feel better than they have in their whole adult life, in many cases. This is ridiculous. This is what we should be focusing on. I'll talk more about other mythologies of TRT in some other videos because this is a topic that's worthy of really fleshing out. If you go talk to your doctors, right, your other doctors, let's say you want to use testosterone, you have the conversation, 90% of doctors in America are going to really try to discourage you from using testosterone. And they're going to make up things like, oh, it's bad for your heart. They'll just say that. And the research does not reflect that. There's none of this reflects that. It's the total opposite. Or, oh, it's going to make you sterile. Or your hair's going to fall out. Or your testicles are going to shrink, or you're going to get blood clots. So I'm going to talk about some of these other things in separate videos so you can just kind of digest them as you will. But it's a big soapbox issue of mine, so you'll just have to bear with me.